We're really lucky to have Jenni Ilomaki here, who's a Senior Research Fellow at the Centre for Medicine, Use and Safety at Monash University. She has extensive expertise in pharmacoepidemiology and leads a dynamic and expanding research group focused on the analysis of Australian PBS data. She's collaborates with a range of government and non-government organisations, both here and internationally, and is chair of the Pharmacoepidemiology Special Interest Group of the Australian Society of Clinical and Experimental Pharmacologists and Toxicologists. I should have probably left that off, Jenni. It's a bit of a mouthful. She's also executive editor of the British Journal of Clinical Pharmacology. Our next speaker is Associate Professor Suzi Nielsen, who's Deputy Director of the Monash Addiction Research Centre and has been a registered pharmacist for over 20 years. She has extensive clinical experience in the treatment of substance use disorders, including both in specialist drug treatment and community-based alcohol and treatment settings. Her research focuses on understanding how to improve identification and treatment of prescription opioid use disorder, reducing risks and harms, and including through the use of take-home naloxone. And she'll be sort of highlighting today some of the exciting new resources that will be available pretty soon in the naloxone space. Our discussant today is Dr. Pallavi Prathivadi, who is a newly fellowed academic GP who currently undertakes a PhD full-time. Her research is looking to inform the development of an intervention to improve primary care opioid prescribing. So a really important discussant today in terms of thinking about how the research we're talking about today really relates to clinical practice. Pallavi commenced her PhD in 2018 and secured multiple competitive grants and has been named the RACGP's National General Practice Registrar of the Year and Fulbright Scholar at Stanford University for 2020. Hopefully you can get there at some point, Pallavi. She has a long-standing interest in the national and international opioid policy and reducing unsafe prescribing opioids in Australia. So at this point, I'd like to hand over to Jenni to kick us off and to talk about issues relating to the prevalence and incidence persistence of prescription opioids. Please welcome Jenni.
Finally, I got unmuted. I was a bit confused with my Zoom as I would. So thank you, Dan, for the introductions, and thank you for inviting me to speak in this first MARC webinar. Can everyone see my slides okay? Thank you. So I would like to start introducing my topic. So today I'll be talking about the recent trends in prescription opioid use in Australia. And this work is based on, it's a couple of years ago that this work was published by one of my PhD students. So I'll be talking about primarily her work. So like Dan mentioned, my work really predominantly focuses on the pharmaceutical benefit scheme data and analyzing trends and patterns and other things from Australian nationwide perspective on medication utilization, and opioid use is one of my focus areas. So when we go for a bit of background for the opioid use, so this paper published a few years ago highlights the 25-year patterns of pharmaceutical opioid use in Australia, starting from the 1990s. And we can see from these graphs that there clearly has been an increase in the use of most opioids during the past 15 years. So on the left-hand side are the most commonly used opioids, including codeine, oxycodone, tramadol, methadone, and morphine. And we can see that there has been an increased patterns in the use of codeine, which is far the most utilized opioid in Australia. And there has been increases also in tramadol and oxycodone use. And I've put here a red line highlighting when the tramadol and oxycodone capsules and slow-release tablets were listed in the PBS for moderate severe pain or chronic non-cancer pain. So we can see that from 2001 onwards, when these medications were listed to the PBS, there has been an increase in the use of tramadol and oxycodone. So it's really kind of starts increasing after this subsidy change. We can also see from the right-hand side where are the opioids that are less commonly used, so fentanyl and tapentadol buprenorphine on the right-hand side. And we can see from his graph similarly that a lot of the changes that have occurred have really been because of some of the PBS subsidy changes. So if we're looking at the fentanyl, for example, it was first subsidized for chronic cancer pain in 1999. Small increase was observed after the 1999 subsidy change. Then in 2016, the subsidy was changed to include also chronic non-cancer pain. We can see that, you know, an increase in the fentanyl patch dispensing occurred, or the defined daily doses in the use had increased since then more steeply, because more people were eligible then to have PBS subsidy for this medication. And in 2005, there was also an increase in buprenorphine listing for chronic non-cancer pain in 2005. So we can see that there was an uptake also in the buprenorphine since 2005 onwards. So this is just a bit of background when I'm going to talk about shortly. So clearly the increases have been because the chronic non-cancer pain indication has been coming in. This increase also has coincided with the increases in opioid-related mortality, as well as opioid overdoses and some other harms that Suzi will be talking about later on in this symposium. So coming to this, this topic of my talk is, so like I mentioned, I'll be talking about two papers that was published by one of my PhD students, Dr. Samantha Wood, and other collaborators and Samantha's other supervisors. I'd like to also acknowledge for this talk. So Professor Simon Bell from the Center for Medicines Use and Safety, and Dr. Natasha Chise from the National Drug and Alcohol Research Center from Sydney. So first I'm going to talk about the prevalence and incidence of prescription opioid use in Australia since 2013, which is continuing to the graph that I was showing you earlier. And for the second part of my talk, I'll talk about the persistence in the opioid use, prescription opioid use among people specifically without cancer. So for this work, we utilized data from the Pharmaceutical Benefit Scheme, like I mentioned earlier. So data was analyzed from a 10% random sample of Australians that are eligible for the Pharmaceutical Benefit Scheme claims. All dispensing records are included in this data for the 10% random sample from March 2005 onwards. However, the medications that are priced below the co-payment level, so they are cheaper than what the co-payment level is, are only available from July 2012. And this is why we investigate opioid use only from the July 2012 onwards. So data includes the date of prescribing, date of supply, the pack size and the strength of the opioid, and some other data specific to the medications and the person's age and sex. So when we put the cohort together for this data for looking at the incidence and prevalence for opioid use, so we included every person who had dispensed an opioid between July 2013 to June 2017, so over a 4-year period. And the incident uses was defined that was the first opioid dispensing within 12-month period for that person, and the prevalent use was defined as any dispensing over that financial year. And what we did was that we calculate the incidence and prevalence based on the data from the Australian Bureau of Statistics on the number of population in Australia on that particular year. So then we could extrapolate our numbers to represent the Australian population when we multiplied the numbers by 10. So the incidence of opioid use really hasn't changed much during that 4-year period. So if we look at that specifically with the people without cancer, we can see that the incidence has been about 10%. So about 10% of Australians had a medication, opioid dispensed for the first time within a year in each of these years. There was a slight decline in the last year, so from 10% to 9.8%, but the decrease wasn't big. It's just that with large data set, everything becomes statistically significant. The prevalence similarly hasn't changed much, so we have about 15% of people who use, or just over 15% of people who use prescription opioids each year, and quite stable for the last 4 years. So when we compare to the graphs that I presented you earlier, this demonstrates that the change hasn't been large in terms of numbers of people using opioids within the last 4 or 5 years. However, we still get large numbers of people utilizing opioids in Australia. If we're looking at the different opioid types, so just the 3 most common opioids that were dispensed, we can see that there's a slight decline in codeine dispensing over time, when numbers of people had been dispensed codeine, and a slight increase of oxycodone. So we can see that the oxycodone is kind of taking a larger proportion within the opioids that have been dispensed for the first time for these opioid initiators. We can also see that there's a slight increase in the amount of opioid people have been dispensed for the first time. So these are the oral morphine equivalents dispensed so that we can standardize all the opioids across the different types. So it's just the standard way of presenting different opioid, whether it's an oxycodone or morphine or codeine. So you can see that there's a slight increase in the higher oral morphine equivalents and a slight decrease in those who've been dispensed less than 100 oral morphine equivalents over time. And we're looking at the difference with prescribers as we would predict. The general practitioners mainly prescribe codeine, same thing with the dental practitioners. So really having those minor pains. And then the oncology interns, hospital interns are more likely then to prescribe the oxycodones and other strong opioids, and the codeine is far less pronounced there. So from this study, we could conclude that there is about 3 million Australian adults each year who have being dispensed an opioid, and just under 2 million Australian adults who initiate a new opioid each year. So after we had this information from the study, we really need to know, well, what then? We know how many people initiate or use opioids, but how do they persist once they start using the opioid? So what is the more defined pattern of use? So we went and investigated the 1-year persistence of the opioid use among those who used the opioid for the first time. So what we did, we conducted this method called trajectory modeling. This is a way where 1-year persistence is easy to describe for those kind of medications that are not taken every day, taken in a standard pattern like cardiovascular medication that you take 1 tablet a day, when opioids can be taken depending on the pain severity and the level of pain. Sometimes you might use it as a little, you have a period where you have stronger pain, you use the opioid, then you might have gaps in use. So in a way, this trajectory modeling tells the story a bit easier for the opioid dispensing than the methods that we traditionally use to describe persistence. So usually what we do is that we look at the gaps of in dispensing patterns, and that's how we define persistent use and those who discontinue. But with opioids, this wasn't a way to go. So we decided with the trajectory modeling that would suit better for this opioid data. So just going straight to the trajectories. So this is what we found. So when we look at the trajectories of opioid use, and then how the model works is that the computer assigns people into different clusters or trajectories based on their dispensing patterns. We found that there's about 10% of people, about 9% of people who became persistent users over a 1-year period. So the red line here at the top, we can see that these people persisted the use over the 1 year. And basically all the rest of the users either have no use for the remaining of the year after they first initiate, and there might be people who come and pick up the odd prescription during the year, but the persistence is not there. So what we did was that we divided this opioid initiated into those who were persistent and those who were not persistent. And then we investigated the predictors of those who became persistent. So looking at a bit more detail, what kind of people they are who remain persistent users of opioids. So these are the characteristics of those 11,000 people who became persistent users versus the rest who were not persistent users. And we can see that there is some demographic differences. So the persistent users really are a bit older. And just to flag here that these are these trajectories are among those people who don't have any indication that they would have a cancer. So we try to characterize the people so that we only included those who are most likely to use the opioid for chronic non-cancer pain. So the mean age of the persistent users was 64 versus 48 in the non-persistent group. There are a little bit more females in the persistent group. And some of the opioid characteristics, interestingly, are different. So those who were persistent users more likely to initiate on strong opioid and a route that is transdermal instead of oral. And just a little bit about the opioid types. So you can see that the tramadol is more common to be as an initiation drug for those who are persistent users, same for morphine, buprenorphine and oxycodone, while the codeine is more likely to be among the non-persistent group as the drug of initiation. A little bit about the comorbidities. So depression far more common among those who become persistent, same with psychotic illnesses. And just an overall number of comorbidities is higher in the persistent group. And similarly, there's more prior medication use in those who are persistent users, mainly analgesics and benzodiazepines. Just the same in the multivariate model. So we can see that the odds ratios for the becoming a persistent use is similar to what the percentages demonstrated. So the higher the age, the more likely the person is to become persistent user. The stronger the opioid, the route predicts persistent use and the increasing dose at initiation, and as well as the increasing number of comorbidities and psychotic illnesses, depression, and other medication use. So just to conclude this study, so we have about 2 million adults who are estimated to initiate opioids each year, 3 million adults who use opioids in Australia each year, and there was a slight decrease in the opioid initiation between the 2013 and 17. It's a very small decrease, and it's not known whether this decrease really translates into decreased harm at this stage. And approximately half of all opioid initiations were initiated by GPs. And that's really from me. Oh, sorry, just to conclude for the second part, I'm sorry, I was ahead of time. So we did find that there were about 50,000 people each year in Australia become persistent user. And as mentioned earlier, so there's really the transdermal formulation and the higher dispensed quantity that predicts the persistent use, as well as older age and prior history of mental health, mobility, and use of other analgesics as well. So I would like to thank everyone who listened, and I'm happy to answer any questions that you may have. Thank you.
So I think I'm leading off after Jenni. Hopefully you can see my slides now.
Sorry, I think I need to stop sharing my screen. I was just waiting.
Oh, okay.
Any questions or take the questions only?
Yeah, the questions are going through to Pallavi at the end, Jenni.
Yeah, the end, yeah.
She'll be,
yeah.
be looking at the questions.
There we go. So are my slides sharing now?
Yeah.
Great. Let me just. So I'm going to be talking about prescription opioids and looking at more of a focus of understanding harms and improving safety. Let's just see if I can advance my slides. So in terms of opioid-related mortality in Australia, there's a lot that we know about prescription opioids now, and Dr. Ilomaki has given us a really excellent presentation that highlights just how many prescriptions are supplied in our community each year, and also the number of new initiates. So 2 million Australians initiate opioids every year, which I think is a fairly profound statistic. And of those, 50,000 develop long-term use. So I think this really highlights why we're probably seeing this rising prevalence of problems in our communities. We also know that when we look at who is dying with opioids, that most deaths from opioids in Australia are still associated with prescribed opioids, so around 65 to 70%. And I think this makes it really important to understand what's driving these deaths and how we might be able to prevent them. I think it's interesting to note that compared to 20 years ago, when most of our opioid-related deaths were actually involving heroin and younger people, we know now that the average drug-related death in Australia is actually a middle-aged male taking pharmaceutical opioids in the context of polypharmacy. The final thing I just wanted to note is that while we are focusing on the webinar today on prescribed opioids, you can see on this graph that heroin-related deaths are also rising, and this also needs attention. So the fact that this webinar focuses on prescription opioids in no way diminishes the importance of responding to heroin-related harms. So Amanda Roxburgh released a study last year that looked more closely at prescription opioid mortality. And this starts to unpack some of the nuances here. So there isn't one group that is affected by prescription opioid harms. There are many different populations and many layers of complexity. So overall, when we look at prescription opioid deaths, we see from the figure on the left that 1 in 4 are actually intentional, and there's a further 1 in 5 when the intention is unclear. So we've got overall with prescription opioid related deaths, just under 6 in 10 are notionally called accidental. I dug into this a little bit more to look at just those opioids that are used for pain, so taking out those numbers that are associated with methadone and buprenorphine, which are used for treating opioid dependence. And when we do that, I think the picture becomes even more clear in terms of actually half of those deaths involve people who have chronic pain. And only 1 in 4 of those deaths, there is any documented history of injecting drug use. And actually half of those deaths are documented to be either intentional or undetermined. So I think this really puts a bit of a focus on where we need to think about broadening our responses, and that we often talk about these deaths as largely accidental. But when we start looking at these opioids for pain, we see quite a different picture. Oops. So I'm going to talk about two pieces of work today that focus in different ways on understanding or improving our responses to these harms. So the first piece of work I'm going to talk about considers how we talk about reducing opioid-related harm for people taking opioids for chronic pain. And the reason I'm focusing on chronic pain here is that we actually already have fantastic peer-led and peer-informed responses for people who inject drugs in the area of overdose prevention. So there's a really long history stemming from work in the US and Scotland, and even in Victoria for groups like VivAIDS or now HRV, that have looked at developing responses to prevent harms for people who inject drugs. But this is not the case for opioids for chronic pain. And so when we started to look at what resources were available for different populations, we found that many of the resources weren't particularly salient for people who were prescribed opioids. And if we wanted to meet the needs of that population, we really thought we needed to take a different approach. And we wanted to see if we could actually improve communication by designing resources with both pharmacists and people with chronic pain. The second piece of work that I'm going to talk about is aimed at getting a better understanding of the context of use that leads to harm. And I think this is really important given how prevalent we see these intentional or undetermined deaths in our statistics, to know what might be driving that use. So when trying to reduce opioid-related harm, one of the key strategies has been take-home naloxone. So take-home naloxone refers to when lay people, so people in our communities, family, friends, carers, and people who use opioids themselves, are trained to identify the signs of opioid toxicity and to be able to respond by calling an ambulance and administering naloxone. So tragically, we know from coroner's reports and other reports that often there are key signs of laboured breathing or respiratory distress, like snoring or gurgling sounds, that are documented, they were witnessed, but they weren't acted on because they weren't identified. And some of the research that I've been involved in has shown that for people with prescribed opioids for pain, that they're not necessarily familiar with these signs. Importantly though, when we talk to them and explain what naloxone is, we've discovered that most people would actually appreciate or in fact expect that a health professional would offer it to them. Some of the research we've done with pharmacists has shown that we know pharmacists supply almost all the opioids in the community. They've actually been able to supply naloxone without a prescription since 2016. But we find that very few pharmacies are actually stocking and supplying it. And often this is due to either a lack of knowledge or awareness, or a lack of confidence, or feeling that there isn't an opportunity to supply naloxone. So I think we've identified some key areas where there's a missed opportunity and where we might be able to improve conversations and interactions around opioid safety. So the work that I'm going to present initially was a project funded by the Department of Health and Human Services in Victoria and led by Isabel Volk, who did very much of the work involved here that I'm going to present today. She's on the picture on the screen there. We conducted focus groups and individual interviews with people who take opioids for chronic pain, and also with pharmacists. And we heard about some of the barriers to having conversations around opioid safety, and also about some of the preferences from both the pharmacist and the patient perspective in terms of how we might improve things. So we didn't want to reinvent the wheel, and we did review a really wide range of available materials, including with people who are prescribed chronic pain, and found that there was a bit of a gap in suitable materials. So just briefly to summarise some of the key findings from the conversations that we had with pharmacists, we found that often they weren't sure how to start the conversation. They didn't necessarily feel like they had the right words, and there was also a concern that patients wouldn't be receptive. And you know, they were obviously aware that there is stigma around overdose. They also identified that there was a lack of tools to kind of support the conversations, and they were really keen on having things that were kind of like short, high quality videos as opposed to long training sessions. From the patient perspective, we heard that patients are actually really aware of a lot of the bad news around opioids, and actually feeling quite targeted by many of the changes, and quite sort of sensitive around you know, fear of whether or not they'd be able to continue being able to access their pain medicine. So what patients were keen on is being able to be empowered to do something about their safety around opioids. We did find a lack of awareness around signs to look for, and a lack of familiarity or awareness that there was even an intranasal naloxone product. And we found that there were really divergent definitions and understanding of what an overdose even was. And I think that most of the materials I'm going to talk about now, these are actually just being launched today, are available at the website there. And I think that Kelly will probably pop that in the chat box for anyone that wants to have a look in more detail.
That's
so one of our key, you've done that. One of our key findings was that the term overdose in itself seems quite problematic, and language when we talk about opioid-related harms is really important. So one of the things we found is that, you know, a health professional might be talking about overdose, thinking that they're talking about severe side effects, but what the patient is actually hearing when they hear this word overdose is something different. So often overdose is assumed to mean either illicit drug use, intentionally taking too much, or addiction, or a whole range of things that aren't actually what we're talking about when we're talking about opioid safety and naloxone. So there's a real risk that the messages aren't effective, or they're not being heard, or they're being discounted because they're assumed to be irrelevant just by having that word overdose in the title. So based on this, we came up with some really basic resources and information sheets and some very short videos to be able to communicate some of these messages. The information for pharmacists isn't prescriptive, but it has some key points about some of the research and statistics, some key counselling points that are important, and also a range of conversation starters and ways to speak to patients that might be helpful. We also have a flyer for patients that mirrors this information, reflecting what we heard. And we actually got some feedback on these, and got some really nice feedback that these did meet the target in terms of being easy to understand, and the best thing since sliced bread, which I thought was nice feedback. I'm not going to show the animation, but we do have a short animation in response to what pharmacists indicated would be helpful. It's pretty short, it's 4 minutes. I've pulled a couple of screenshots that really highlight some of the key points around normalising naloxone and prevention, risk reduction, the importance of language and signs to look out for, and also some key points just around naloxone administration itself. There's also a short animation for patients that's oriented towards information that's relevant for them. And this is all part of a key strategy in raising awareness and facilitating those better conversations. So this is one step in terms of reducing opioid-related harm. But the other key thing that I want to talk about is understanding what's driving the use that leads to harm in the first place. So the second piece of work I'm going to discuss is focusing on a study that aimed to understand the context of opioid use that leads to harm. And our research group and many research groups have looked at bigger data studies that really quantify harm and correlates and predictors of harm. But there have been very few studies that have actually really looked at what drives the use on the occasion that harm occurs. So this is what we did here. James Wilson, who you can see pictured on the screen, was the driving force behind this work, and you can see the study team are all listed on the screen as well here. And this study was really trying to understand what the context of use was, and also how that varied between different opioids. So we looked at 2 different opioids in this study: oxycodone, an opioid with a well-established abuse liability, and tapentadol, which is a newer atypical opioid, to try and understand the context or the range of contexts that lead to harm, to try and inform more appropriate interventions. So when we looked at attendances from extramedical use with tapentadol and oxycodone, the first thing that we found, which was quite striking, is that these were much more similar than they were different. So we looked at 82 cases with tapentadol, which was all of the cases that appeared between 2013 and 2018, and then a representative group of the same size of oxycodone cases, which was drawn from more than 5,000 ambulance attendances involving oxycodone over the same period. So we looked at paramedic notes from each case, which contains a description of the event, and using framework analysis developed an initial coding framework to look at the primary context of use in each of these cases. And we had a lot of robust discussion amongst the study team, but ultimately coded all of these cases and to identify some of those most common contexts. So what we found is that psychological distress, physical pain, and social stresses were really driving a lot of the use that led to harm with these attendances. And interestingly, opioid use disorder, or sort of problematic opioid use, which has a lot of, I think, focus and policy focus, was relatively less common. We also found that suicidal intent was commonly expressed alongside some of these themes. So just to give you a few more examples of our most common contexts. So psychological distress and pain represented most of the presentations that we saw. And this was, when it comes to psychological distress, this was used to relieve mental health symptoms, and with pain often used in the context of trying to manage unrelieved pain. So you can see on the left here, we've got these common descriptions of trying to get away from unpleasant feelings or escape unpleasant feelings. And this is often in the context of using multiple pharmaceuticals in addition to alcohol. On the right-hand side, you can see some examples of the kinds of descriptions we had with pain. So often pain from injury, trauma, or surgery, and commonly this was people who are experiencing chronic pain. And you can see these examples of people taking, multiple blister packs or multiple medications in response to just having a lot of pain or being really fed up with pain. And then the last example on the right-hand side highlights when, due to both recent stress and chronic pain, there was an attempt to end someone's life. And I think this just really reflects just how distressing and challenging this experience can be when people are using these opioids to try and relieve these symptoms. On the other end of the scale, we can see opioid use disorder. So this was present, but it wasn't the most dominant theme. And I think this is where a lot of attention focuses on people who might be using opioids in the context of opioid use disorder. But in terms of the harms that are represented with ambulance attendances, it was roughly 1 in 15 cases. But there are cases where, for example, this case, oxycodone was used to overcome withdrawal symptoms from opioids in the context of someone that had long-term opioid use. So I guess the questions that this raises is, how well do our current prevention strategies fit when we look at these presentations with really high levels of comorbidity, multiple medications, and this isn't just opioid use, this is a whole range of pharmaceuticals, presentations with stress and distress and chronic pain all contributing. And I think we have, we really are developing prevention strategies targeted around unintentional opioid harms, like the example of the work that I presented earlier. But I think we need to go beyond that to look at intentional use with multiple pharmaceuticals in response to distress. And I think when we think about our current environment, we see a lot of restrictions around people accessing pain medicines that are being put into place. Is there, we might need to understand how that might affect those that are already feeling distressed, and also looking at how we can best deliver responses for those individuals, and how we can deliver responses during a pandemic when there's a whole range of other potential stresses, mental health stress and potentially economic stress, that are going to continue to add to this picture. So my final slide, I'm almost there, but I just wanted to mention that I've briefly spoken about 2 pieces of work, but I think we need to remember these are just 2 parts of a large puzzle. And I've got a bit of a laundry list of things here that I think are important. So just to briefly note that as Jenni highlighted, it is important to think about transitions to long-term use and how we can reduce those in a really preventative sort of framework. So things like opioid stewardship, the changes to have smaller pack sizes for acute pain, and a changed culture around pain management are all going to contribute to that. But we have a separate cohort of people who are already using long-term opioids that need different responses. So monitoring outcomes, monitoring for signs of either loss of control over opioid use or distress or mental health symptoms. And we need affordable non-drug pain alternatives for treatment, because at the moment, some of those treatments are not financially affordable. And better ways of identifying where risks are outweighing harms. But I think it's really important to remember that we're avoiding sort of forced taper, which we know outcomes can be bad and can really contribute to distress. Some of the work I've already presented talks about naloxone supply and education and really just normalising those conversations. I think we still have huge barriers in treatment for those that are experiencing opioid disorders. It's much easier to access often pain medicines than it is to access treatment where problems are emerging. And I think the big gap is really thinking about these unintentional harms and this grey area where people might not necessarily be intending to harm themselves, but they just want this severe pain or unpleasant feelings to go away. And it's a very sort of difficult and complicated scenario. So just to finish, to acknowledge the collaborators on these two pieces of work, and thank you for your time. And I will stop sharing my screen and hand over to our discussant, Pallavi.
Thank you, Suzi. I'm just going to share my screen before I get started. I'm just going to minimize this. Thanks, Suzi, Jenni, and Dan for this webinar, and to the 120 something people who have joined on a Thursday afternoon to hear some really fantastic research being done in an important area. I'm just going to wrap up the session and then open to a Q&A. But if we just kind of summarize some of the main concepts, because we've covered a lot of important things. So Suzi was talking to us a little bit about, can we predict some of the people who are at risk of opioid-related mortality? And she talked about how the drivers of intentional and unintentional prescription opioid-related harm are actually quite different. And a big group of people that we need to talk about are the ones who are taking opioids for chronic or persistent pain, and therefore are on long-term opioids. Now we know that there's a huge overlap between pain and mental illness, and where there is concurrent mental illness that's quite severe, like depression with self-harm and suicidality, we need to keep in mind that these long-term opioids may actually be contributing to increasing harm with intentional use or even accidental use that's leading to death. Now, Suzi mentioned that there are different things that we need to consider and try and do to reduce the opioid-related harm in this population. And one of the ways is actually through things like this webinar, where we're increasing awareness and talking about these important issues. We need to try and get some of the stigma away from this conversation. And she was presenting some of the results from that study, which was talking about, you know, what is overdosing in the context of prescription opioids versus, say, something like heroin, and the way people are understanding that. There's obviously a big role for take-home naloxone, and it seems like there's a lot of people who are receptive to that. And maybe pharmacists have a big role in helping to navigate this and open up that conversation. Now, can we predict problematic use from prescribing data? So Jenni spoke to us about the usefulness of PBS data, and that we can use it not just to look at trends in prescription opioid dispensing over longer timeframes, but also potentially some factors which might be associated with that persistent opioid use. So people who are still on these opioids 12 months later. And some of the factors that she found in her research were the older age of the patient, a mental health comorbidity, which is particularly important if you consider what we just spoke about with Suzi's research. Being started on a transdermal formulation like a buprenorphine patch, and a higher total dispensed quantity. Now, my particular area of research ties in really nicely here, because Jenni was touching on the role of GPs in firstly prescribing and initiating these long-term opioids, but also monitoring use. And now with this increasing research being done, recognizing risk factors in patients that might lead to persistent opioid use. So my particular PhD and what I do is really looking at GP opioid prescribing behaviors. And we know that about half of all of the prescription opioids in Australia are written by GPs, and about half of this is for chronic non-cancer pain. And this is an area where we know that opioids have a modest therapeutic benefit at best, and carry serious risks of dependence and harm. So the big question is, why do GPs prescribe opioids, and what are the factors that influence their prescribing decisions, particularly for this cohort of chronic non-cancer pain patients? Well, there's definitely system factors, which Jenni touched on when she pointed out the increasing availability of certain opioids through the PBS and the resulting increases in prescribing rates. There's patient factors like unrecognized dependence, and what Suzi was telling you about, which is the concurrent mental health illnesses. What I look at is the prescriber factors. Is there a lack of knowledge of best practice guidelines? Well, my qualitative and mixed methods work suggests that no, that's not actually the case. A lot of the GPs in my interview studies were telling me they perceived a benefit in using long-term opioids, particularly for older and elderly patients with osteoarthritis. And I think that's definitely something that we've seen in the earlier part of this webinar through things like buprenorphine. Now, the younger GPs, particularly registrars, seem to be influenced by their peers and role model their prescribing on their GP supervisors. So there's a huge proportion of social learning involved in this. And perhaps there is a component of GPs and prescribers who have difficulty saying no when patients request opioids, when they recognize that they're probably not evidence-based. So some of the interventions in this area might actually involve also training in communication and improving patient literacy. So as Dan mentioned earlier, I'm trying to develop prescribing intervention, and this is an area that a lot of people are working on. And so what we need to do when we develop prescribing interventions targeted at GPs is to consider the multitude of factors that actually contribute to prescribing decisions. And remember that GP opioid prescribing is actually remarkably patient-centered and well-intended. And in my particular research, I really found that the GPs were trying to treat quality of life, which is the theme that also came up in the qualitative work Suzi was undertaking. And the patients were reporting the use of just, wanting to have a better improvement in their control of pain. So I'm just going to open it up to some of the questions. I'm going to stop screen sharing if Jenni and Suzi are okay to take a couple of questions. If you have questions, please enter them in the Q&A box. We've got about 10 minutes to try and get through as many as we can. Now, I think a question for you, Jenni, that we got is really about non-PBS data that we have, or private scripts. And I wondered if you might be able to comment on some differences between PBS and private scripts, and if we're able to get any information from that.
Sure. Of course, one of the limitations in this study is that it's only, what we looked at are only those that are dispensed through the pharmaceutical benefit scheme, and there will be people who will receive medications as private for a few reasons. First of all, in some pharmacies, you'll get them cheaper via private script without the dispensing fee. And secondly, it doesn't then register as in many places with the medication that you received. So there is some earlier studies that have looked at sales data that about 20% of codeine that has been dispensed as a private script. However, it is quite tricky to get data on the private scripts. So sales data is probably the best way to capture all prescription medication sales, and then we can then look at the overall sales and then estimate how much of that was via PBS when we compare the PBS to the sales data. There are also ways that you might be able to analyze all medication dispensings from a pharmacy via other venues than the PBS dispensing records, but that's not widely done in Australia yet, so there isn't really much research done on that.
Thanks, Jenni. Now we've just got a question about what's the responsibility of GPs prescribing opioids, and what support do GPs get when they determine if someone is a persistent user? And I'm happy to comment on this, but I wonder, Suzi, you just touched on some of the changes that are happening with opioid prescribing through the PBS and some of the increased regulations. Would you be okay to just kind of touch on some of the changes that might involve GPs?
Yeah, I think that's a really interesting point, because we have just had a range of changes that have really impacted on both prescribers as well as patients, and I think some of those have been really challenging when maybe when what looks like optimal from a policy level, maybe the GPs aren't necessarily supported to do. And we know that, for example, there is an emphasis around deprescribing at the moment, but sometimes that can be easier said than done, and not all patients are able to or willing to come off opioids, and there are many patients that it might not be appropriate as well. So I think we really do need to provide GPs better support in terms of being able to assess that benefit and risk profile. But also, I mean, some really kind of system level things, the way that the funding model that GPs are reimbursed, it really doesn't, those sort of short appointments don't really speak to the kinds of complexity of the presentations that I think were highlighted through the ambulance data that we've looked at. When we see these patients with multiple morbidities and multiple medicines, and that's very challenging to manage in a short appointment. And what ends up happening, my understanding is that often that's kind of unpaid work when you're spending a lot of time trying to coordinate all of those things with multiple health professionals. So, I mean, you can comment directly, Pallavi, but that's my sense, is that we need some system level changes to also support the kinds of treatment models that would provide good solutions around chronic pain.
Yes, I completely agree, Suzi. And I think particularly a lot of my research is really asking GPs about their own experiences with this issue. And, you know, a lot of the narrative that we heard was that a lot of patients who are on chronic or long-term opioids have lots of psychosocial issues, the mental health issues, perhaps housing, domestic violence, many other issues that are a little harder to treat, particularly when you consider the whole biopsychosocial model of pain, and that writing an opioid script was perhaps the only thing that the GP actually could get done in a 10-minute appointment, which again is GPs trying to improve quality of life. We have another question here about naloxone. I wonder, Suzi, if you'd be happy to answer another question.
Sure. Yes.
The question is, someone's experience is that illicit opioid users are open to naloxone, but from this data, that is not the at-risk group. And what strategies could improve general public uptake?
So I guess I would say two things. Firstly, that this data has focused on prescription opioids. And so probably around half of these deaths are, up to half of these as may be represented by people who are using these prescription opioids non-medically. So it still is an important group. And also we haven't talked about heroin related deaths. And so there is, when we look at overall all opioid related deaths, I wouldn't want to give the impression that people who use illicit opioids or heroin aren't really important. They are a really key group, but there has been a lot of work done. So I think they are also have greater knowledge and are open to that as open to receiving naloxone. I think it's just a less familiar conversation when we talk about it amongst the general population. And I think that there is enormous stigma around substance use. The term overdose carries a lot of kind of baggage. So part of it, I think, in terms of being able to reduce stigma and have more conversations, is just highlighting that these are just inherent risks with these medicines. It doesn't say anything about the patient when you're offering them naloxone, other than the fact that they're taking a medicine that carries with it a risk, and there's something that they can do to reduce that risk. But I do think, I mean, we do have a lot of work to do, you know, at the community level and the population level around reducing stigma associated with substance use, which is often where a lot of this stigma comes from. And so really changing the conversation in those ways around all levels of preventing harm around opioids.
I wonder, Suzi, if some of this is the same as in our diabetic patients who are on medications like insulin, where we make sure that they always have a plan if they have a hypo and their sugars drop, carrying things like jelly beans. And it's we're trying to avoid the stigma around all of that. And maybe that's what we need with naloxone as well as the whole.
Yeah, just normalizing that if you're on the opioids, it's a great thing to have in the home and normal part of a first aid kit. And it would be great to have naloxone more available in many settings where people might, you know, witness and be able to respond to opioid related harms.
Okay, I think we're going to try and finish on time today. So I'm just going to actually close off the Q&A session, and I'm sorry that we didn't get to cover everyone. I think all three, Jenni, Suzi and myself, are happy to be contacted if you have any follow-up questions for us. But I might just head it back to Professor Lubman to close the webinar.
Thanks, Pallavi. Yeah, no, it's great. You know, such a great webinar, and obviously, you know, with International Overdose Awareness Day on Monday, really topical that we talk about the subject of prescription opioids, and particularly the factors that lead to mortality related to prescription opioids. And really fantastic to hear both from Jenni and Suzi, what the latest data is in this space, and also what we can do in terms of key responses. I think one of the key take-home messages, from today is that while the work we're doing in the space around reducing harms relating to opioids, particularly in relation to promoting opioid substitution treatment and addiction treatment more broadly, in terms of increasing uptake of naloxone and certainly increasing the number of supervised injecting centres, they're really critical in reducing prevention and reducing some of that accidental mortality. But I think what's really clear from Suzi's data is that we need to think a lot more about intentional deaths associated with prescription opioids and think much more broadly in that space around what the type of strategies we need to make sure we can start to decrease these really tragic numbers. So at that point, before I thank the speakers, let me again just reiterate, this is the first inaugural of a whole series of webinars we're hopefully having, with 4 for the rest of this year. The next one will be on Thursday, September 2020 at 2 o'clock on substance use and mental health. And we've got some great speakers, Paul Dietz and Chris Pearce, talking about their respective data sets and what we're learning around the impact on substance use and mental health. And Shalini Arangiri, Addiction Scout, is going to talk to us about some of those clinical aspects and what it means in terms of practice. At this point, so we can finish on time, can I thank everyone for attending this first meeting? I think it was, incredibly important topic to talk about, and please join me in thanking Pallavi, Suzi and Jenni for a really fantastic discussion. Thanks so much, and we'll see you again on the 17th of September. Thank you.